Good morning, everybody. Thank you so much for joining us today for Top 11 Things to Know About Alzheimer's Disease Psychosis. My name is Lauren. I'm the Educational Services Manager here at Alzheimer's Orange County, and I will be your presenter today. I want to quickly thank Acadia Pharmaceuticals for sponsoring this event so that we can bring this important topic to the community. Before we begin, at any time, if you have any questions, please feel free to put it into the chat box, or you can come off mute and ask it that way. I encourage active participation and to make this interactive. So today we're going to be covering 4 objectives. We'll be understanding the link between Alzheimer's disease and psychosis, identify the top signs and symptoms, explore management strategies and for caregivers and professionals, and learn about available treatment options. So in 2021, over 57 million people across the world were living with dementia, and about 60 to 80% of dementia cases are Alzheimer's disease specifically. And 30% of those people with Alzheimer's disease experience symptoms of psychosis. So what do those numbers mean? In the United States, there are about 6.9 million people living with Alzheimer's disease. And of those 6.9 million people, about 2 million people are experiencing symptoms of psychosis, which is primarily hallucinations or delusions. Now, psychosis is when a person has lost contact with reality and has trouble figuring out what is real and what isn't. And symptoms of Alzheimer's disease psychosis include delusions and hallucinations, which then can lead into behavioral symptoms, such as apathy, anxiety, aggression, sleeplessness, agitation, and lack of inhibition. So again, psychosis is loss of contact with reality, and psychosis involves a disconnect from what is commonly accepted as real, including difficulty distinguishing between what is real and what is not. And psychosis is not a disease, but rather is a symptom. And people with experience psychosis differently, with some experiencing it briefly or episodically, while others may experience it more frequently and consistently. So to take a deeper look into delusions and hallucinations, delusions are false beliefs that are firmly held despite overwhelming evidence to the contrary. So delusions can commonly consist of paranoia, believing that their items have been stolen, or that they have been abandoned, or their spouse is cheating on them. So for example, with a delusion, a misplaced wallet becomes, "You stole my wallet and hid it from me." And it's also common for an individual to believe they have been abandoned when their care partner is not available to them. So for instance, if a care partner leaves to go to the grocery store, the individual with dementia may feel like that they've been abandoned, that their loved one's never coming home. However, delusions do not always need to be frightening or distressing. They can sometimes be pleasant. So for instance, many years ago when I was working in a memory care, I had one of our residents who believed that she was close friends with Alex Trebek, and that Alex Trebek was always talking about her legs. She would say, "Alex Trebek said, Janet, you got some good looking legs." She would go on about her day, always talking about Alex Trebek. She had never met him before, but that was just something that she believed, and it brought her joy to talk about it. Hallucinations are sensory experiences that occur without any external stimulus, so leading to the person to experience something that others do not. So that would be when they're seeing someone, hearing, or believe spiders are crawling on them. People experiencing Alzheimer's disease psychosis most commonly experience visual hallucinations. However, hallucinations can involve any of the 5 senses, so such as seeing things that are not actually there, such as objects, animals, people, hearing sounds that others do not, such as voices, music, or random noises. They may smell odors that are not present, such as food or smoke, and tasting things that are not in their mouth, such as food, metal, or poison. And they can also then feel sensations on the skin as well, so such as crawling insects, burning, or tingling. Of the two, delusions are most commonly experienced. And just to differentiate, because there's sometimes other symptoms. When we think about schizophrenia, we think about delusions. It's very different. Schizophrenia induced delusions versus delusions associated with Alzheimer's disease psychosis. With schizophrenia, we tend to see bizarre delusions such as aliens stole my organs. And then also there's something called anosognosia. It's always a hard one to say, which is a lack of awareness or insight into one's own medical or psychological deficits. So this is very different than delusions. It's just the lack of awareness, that believing there's nothing wrong with me. So just to keep those in mind about those two, that they're completely separate. So why does psychosis occur in Alzheimer's disease? There are many reasons, and it's something that's actively being studied. There's no one exact cause, but scientists believe that it's due to damage to the brain, because the areas of the brain that are impacted by Alzheimer's disease which cause damage to the brain are going to be the hippocampus and the temporal lobe, which are responsible for processing sensory information and memory. And this damage leads to misinterpretations of external stimuli, which then leads to hallucinations and delusions due to the inability to accurately recall and integrate the information from the environment. So essentially what the brain is trying to do is connect dots without all the necessary information, and will then fill in the gaps on its own. So for example, if there is a television on, but the person with Alzheimer's disease is unable to see it, they may hear the noise and believe that people are talking in the house. Or if they don't remember where they put their jacket, they're trying to connect the dots and they assume that the jacket was stolen rather than they forgot where they put it. Hallucination and delusions are especially prevalent in the later stages of the disease as cognitive decline worsens. So again, as memory is becoming more impaired, the brain is just working that much harder to connect the dots. And then additionally, with neuroimaging studies, it suggests that people with Alzheimer's disease psychosis demonstrate greater cortical synaptic impairment than those without psychosis. So we're already seeing that there are brain changes, and those brain changes then lead to the psychosis. So this is due to reduced gray matter volume, reduced regional blood flow, and reduced regional glucose metabolism. So if your brain structures of the brain can therefore impact your risk of getting psychosis. And a number of studies now indicate that more rapid cognitive deterioration begins before the onset of psychosis, beginning during the early stages of Alzheimer's disease, subsequently manifesting as psychotic symptoms. So for example, greater cognitive dysfunction was already present in the earliest stages preceding the onset of psychosis. So those that are experiencing a rapid cognitive decline are at a higher risk for developing Alzheimer's disease psychosis. And delusions and hallucinations in Alzheimer's disease are associated with different characteristics. And a memory clinic sample of people with probable Alzheimer's disease, delusions were associated with older age, depression, and aggression, whereas hallucinations were associated with more severe dementia and longer duration of illness. So again, the more severe the dementia and the longer the individuals had that disease, they're going to see more hallucinations, rather than someone who is of an older age, maybe has a history of depression or aggression, is more susceptible to experiencing delusions. And persecutory delusions, such as delusions of theft, are the most common late life delusions, and they occur earlier in the Alzheimer's disease course than do misidentification delusions, such as TV signs or phantom boarder, so experiencing that someone's living in their home, which are associated with advanced dementia and grade cognitive impair. So again, earlier stage in the disease, we're going to see more of the persecutory delusions, someone stole something from me, versus later in the disease process, we're going to see more of the misidentification, such as the TV's on, therefore someone must be living in my home with me. And what is the impact of Alzheimer's disease psychosis? Why do we talk about it? So someone living with Alzheimer's disease psychosis is at risk for a shorter life expectancy. So they causes caregiver burnout and overall faster decline. In addition to the individual's distress that delusions and hallucinations can cause, Alzheimer's disease with psychosis is associated with a co-occurrence of other behavioral disturbances, the most troublesome of which are agitation and aggression. And we also see depressive symptoms are also increased with Alzheimer's disease psychosis. And Alzheimer's disease psychosis is associated with greater distress for both the family and the caregivers. We'll see greater functional impairment, greater risk of institutionalization, and worse general health for the patient and increased mortality. People with Alzheimer's disease psychosis who tend to have a faster decline in cognitive function because psychosis in this context is often associated with severe underlying brain damage, leading to more rapid progression of the disease. And it can also significantly impact daily functioning, such as managing self-care, maintaining independence, and impact quality of life, further accelerating the decline. And specifically with caregiver burnout, which I know is probably why, everybody's on this call, is the frustration with working with someone with Alzheimer's disease psychosis. And, when you're trying to say, this is fine, everything's okay, and it's their reality, they're experiencing it and trying to work through that with them. It takes a lot of work and a lot of time. And so we'll talk about the non-pharmacological approaches and medication, which are the two different treatment options. So with symptoms of psychosis, it is important to get a medical evaluation. That must be done first. Diagnosing dementia-related psychosis is mainly about gathering information, ruling out other causes, and then observing, listening, and asking questions. So when you go to the doctor with these concerns, it's very, very important that you come in prepared with a list of what's going on, and having all of that. So it's not just, oh, he's always paranoid. Let's talk about that paranoia. When does it happen? Are there specific instances, specific triggers? And the doctor wants to go ahead and rule everything out because sometimes a urinary tract infection can cause delusion. So it's really important that the doctor does complete lab work, looking over, existing medications. And as a reminder, a person experiencing symptoms should not go alone to the doctor. They may hide their symptoms, or they may not even really be aware of it. So it's important, again, that you're keeping a log of when, what, and why to share with the doctor. Management of Alzheimer's disease psychosis. Oh, we have somebody. There we go. Management of Alzheimer's disease psychosis consists of both non-pharmacological approaches and pharmacological interventions. Left untreated, symptoms may be significant enough to present a danger to themselves or others. And this can be due to agitation, yelling, lashing out against others when feeling threatened, or just overall general aggression. People may refuse care because of paranoia, wander into unsafe situations, or have agitating resulting in injury. So for instance, if somebody becomes so agitated and they start striking out, they lose their balance and they fall. So non-pharmacological approaches consist of creating a calming environment, effective communication, redirecting, and minimizing sensory triggers. So sometimes people with milder psychosis, they may not need treatment. If a hallucination or a delusion doesn't bother the person with dementia, there's often no need to treat it. And that, again, is when we're seeing, maybe someone sitting at home and they're like, oh yeah, the people that live here, they're really nice. And they come in and they, offer me dinner every night. And it's very pleasant. It's not bothering them or causing them any concern. That's okay. If a hallucination or a delusion doesn't bother the person, again, there's often no need to treat it. If it does bother them, some simple methods can help, such as making sure the environment around the person with dementia doesn't trigger the episode. So what do you want to do? You want to make sure the person has regular eye test. We want to make sure the person has up-to-date hearing test. And again, those are going to help minimize sensory triggers. Because again, if the person can't hear or see, their brain is going to try to fill in and connect those dots. So equipping them with glasses and hearing aids will help reduce triggers. You always want to talk calmly to the person and offer reassurance and go with what they are saying. Do not argue, avoid trying to rationalize them out of their beliefs, and just be an empathetic listener. And this is one of the most frustrating things and usually the hardest to do, is because as a caregiver, you want to solve the problem, you want to make it better, and you know what they're seeing isn't real or what they're hearing isn't real. But again, it's their reality and it's our responsibility to walk them through it and be there for them. We want to redirect with a meaningful activity, such as going for a walk or engaging in a hobby they enjoy. And as with all redirection, whenever we utilize that tool, it has to be something that means something to the individual and provides them purpose. So if they're experiencing something and we say, oh, hey, can you help me fold these towels? But they don't want to fold and they don't like folding, we're not going to get the reaction that we want. But if they enjoy gardening or going for a walk, that's the activity that we want to pull them into. And we always want to modify the environment. So create a calm environment, reduce sensory triggers, and provide reassurance. And again, sensory triggers are anything that are going to trigger one of our five senses. So if the room's too cold, if something's too loud, if we can't see, if something we're touching, the tactile is bothering us, that can cause a trigger. And specifically, we're looking at loud noises that they can't see or understand or that they can't hear. So it's when we're thinking about the environment, does their brain understand what's going on? Because if it doesn't, it's going to try to connect those dots and cause hallucinations or delusions. And how can we modify and create a calm environment? We can cover reflective surfaces such as mirrors. So sometimes someone will see their reflection in the mirror and not understand that that's a reflection and think someone's in the house with me. And again, when someone with dementia, they might not recognize themselves because in their brain, they're young and in the mirror is an 80-year-old, and that's terrifying. So if we cover the mirrors, that can be very beneficial. Again, closing curtains to avoid reflections in the window pane, and using plain colored bedding and removing patterned items. So this is very common when there's carpet and there's a pattern design. With dementia, we have trouble with our depth perception and our vision. So we might see a pattern and think that there's holes in the carpet and we might have to try to jump over them, or we might get scared to walk. So it's not ideal to have pattern items, and just having it one color is going to be ideal. So now I'm going to have you watch a short video. These are UCLA Alzheimer's and Dementia Care. They've created these caregiver training videos. These are phenomenal videos and they have topics on just about everything. So I'm going to share this one right now.
My mother's been waking up in the middle of the night and seeing things in her room that aren't actually there. We're both exhausted during the day because we're not getting enough sleep at night. Good night, Mom.
Honey, help me.
What's wrong, Mom?
There's an evil man in the room.
Mom, please. There's nobody here. No one's here. Go back to bed. Come on. Look, there's nobody here. All right? Go back to bed. You've got a big day tomorrow. Come on. Good night, Mom.
A person with dementia may experience hallucinations when the disease affects the regions of the brain that are responsible for interpreting sights and sounds. Hallucinations commonly involve seeing or hearing things that aren't there. They can transform ordinary, everyday experiences into frightening episodes. A good approach to reducing hallucinations is to identify and eliminate the objects or things that trigger them.
Honey, help me.
What's wrong, Mom?
There's an evil man in the room.
Oh, really? Let me take care of it. It's okay. Oh, I see. Okay, come on. Come on, I'll take care of it. Now you stay out here. Now he's gone, okay? I'll sit with you until you go to sleep, okay?
Okay.
You know, Mom, I think we should keep your coat rack outside so you have a place to keep your jackets when you come in.
Oh, okay, dear.
Okay? Okay. Good night.
Remember, patients experiencing hallucinations are having a difficult time interpreting their surroundings. Remain calm, reassuring, and try to identify what may be triggering the hallucinations. If hallucinations persist after trying to eliminate them, be sure to discuss this with their doctor. Here are a few tips on how to reduce hallucinations. Look around and try to see things through her eyes. What might cause her to misinterpret what she sees? Identify potential triggers such as open curtains, shadows, mirrors, or televisions left on. In the bedroom, use a nightlight to create a more peaceful sleeping environment. Always remember to remain calm and reassuring. Do not yell or scold her. Help her back into bed and reassure her that she is safe.
Okay, so such a great video and such a great example of when someone is in bed and when they look around their room and they're seeing shadows and their brain is just trying to make sense of what's going on. So it's really important as caregivers, and again, it's the hardest part, is to not dismiss what they're feeling. What they're seeing is real to them and they are genuinely scared. And so it's important that we meet them with where they are and help find a solution. And so as she saw, and you saw in the video, she removed the coat rack from the room and then covered the mirror, because when you walk by and you just see something, you just don't know what it is. So we're going to run through a couple scenarios that caregivers often face. I encourage you, if you want to, if you've have success with any of these, to again come off mute or put it into the chat box, things that have worked for you. So the first one is delusions about stolen belongings. And Mrs. Jones is 78. She believes her caregiver has stolen her purse. She accuses the caregiver daily and becomes agitated, refusing assistance. Her delusions persist even when shown her purse. So this is always very common, is I can't find my purse. You find their purse, you show it to them, and that's not my purse. That's not what I'm looking for. And that can be a myriad of things. They're no longer remember what their purse looks like. They're maybe remembering a different purse they had at a different time of their life. But what should a caregiver do? So caregivers should validate feelings without confronting beliefs. So responding with empathy. It must be upsetting to feel like your purse is missing. Let's go look for it together. And this also is very, whenever accused with stealing an item, even if you know exactly where it is, because that's where the person leaves it every single day, it's always accepting the blame. I'm so sorry. I must have picked it up and put it, thinking it was mine. Let's go look for it together. If possible, redirect, shift the focus to a comforting activity. Would you like to have a cup of tea while we talk about where it might be? Again, adjusting the environment, designate a specific place for the purse and gently reinforce this location daily. And that gives ownership and control to the person living with dementia so that they, know exactly where their purse is going to be and they can check it as frequently as they want. And making sure to be consistent. And you always want to maintain a calm and consistent approach to build trust and reduce agitation. Unfortunately, with delusions and hallucinations, there's no quick fix. We have to just continue every single day to manage the symptoms and being consistent. And if something doesn't work, we try again. We try a different way and we say, okay, this worked. Let's try that. And some days that will work and some days it won't, but just making sure that you're being consistent and being calm and caring. Second common is hallucinations of intruders. So Mr. Lee frequently insists that strangers are entering his home at night. He becomes anxious, he'll barricade his door, and he refuses to sleep. So what are some things that caregivers can do? Reassurance, always speaking in a calm tone, you're safe here, no one can come in without us knowing. We want to validate with gentle reality orientation. So sometimes shadows or noises can seem like people. Let's check the doors together to make sure everything is locked. So gently explaining why he might be seeing what he's seeing. So that was what we saw in the video where she acknowledged that it was the coat rack that was causing that shadow and removing that from the room, but also giving the person a sense of control over the situation and having them join with you to make sure the doors are locked and everything is okay. Again, it's easy to dismiss and say, I've checked the doors, everything is fine, but you're not providing that reassurance to that individual. So having them comes along with you is very beneficial. Again, simplifying the environment. We want to minimize visual and auditory triggers. So we want to reduce shadows by adding nightlight. We can add white noise to block out outside sounds. But we want to, put ourselves in their room. What are they seeing? What are they hearing? Because there might be a lot of shadows that you're not even aware of that are being cast against the wall. Maybe they hear kids or neighbors outside their window. And again, the brain's just trying to make sense of what's going on. And trying to introduce relaxation techniques to help the person, become more tired and willing to go to sleep. So using music or soothing scents or a gentle bedtime routine to reduce anxiety and promote sleep will be beneficial. And this one, paranoia about medications. I know throughout my career is when I started as a caregiver and I was a med tech, this was probably one of the most frustrating things that I experienced was someone not wanting to take their medications because they would tell me they didn't have medications they needed to take, or they didn't trust me what I was going to give them. And it's you coming from a place like, no, you need your medications. You need to take this. You can skip a shower and that's fine, but you need your medications, right, to manage all of your other diagnoses or help manage your dementia symptoms. So we'll spend this, as you can see, there's a lot to do with this one. Mr. Carter refuses to take his prescribed medications, insisting that they are being used to control his mind. He becomes agitated whenever the caregiver approaches with his pill organizer and accuses them of conspiring against him. So what can a caregiver do? It's important to build trust through empathy. You want to acknowledge his fear without arguing. So saying, I understand this makes you uncomfortable. Let's talk about it and see how we can make it better. Simplify the approach. So present medications one at a time rather than using a large pill organizer to make it less overwhelming. And that can also look like maybe instead of taking multiple medications throughout the day, can I take, all of these medications they be given at one time? Maybe there are, I'm getting ahead of myself, involve a familiar voice. So we can have a trusted family member, friend, or healthcare provider reassure Mr. Carter about the importance of medications. So Dr. Smith explained how your pills help your heart stay strong. Should we call her to talk about it together? So if there is someone that is of a place of authority and your loved one or the person you're caring for listens to them, making sure that they're involved. And I would, when I was a care partner, and we would have someone refusing their medications, we would often call maybe a daughter or a spouse, and they would say, oh no, you remember you need to take your medications, and they would listen to that person and take the medications. We want to offer the individual control. I allow Mr. Carter to hold and examine the medication, present it in its original packing to show it's unopened. So here's the bottle from the pharmacy. Would you like to read the label with me and show that, okay, this is your name, this is your medication, these are your pills, rather so that they have a sense of control and can make that decision for themselves. Always using positive reinforcement. We want to praise cooperation and link medication to his well-being. You've been feeling stronger since starting this medication. It's good to see you feeling more comfortable. Timing and environment adjustments, and this is a really important one. We want to offer the medication at calm and predictable times, avoiding high stress moments. And if we pair it with a pleasant routine like tea or a favorite TV show, that can be beneficial. We often think like, oh, someone with dementia can't form new memories, but it's, the brain continues to develop patterns. And just as if we know that if I have tea before bed, my brain starts to realize, okay, it's almost going to be bedtime. We can make that same association. And if we're, having tea and we're taking our medications, it's a pleasant activity that we're pairing it with. And timing as well. If you know your loved one or the person that you're caring for, if they're, towards later afternoon, if they experience sundowning, or that it's really challenging to get their medications, you want to get them in ahead of time when they're more alert. So talking with your doctor about what times can I take the medications, because certain medications, they have to be taken at night. Certain medications have to be taken before other medications, first thing. So talking with your doctor, okay, what times can I give this medication? You want to, and then, and it's always important to get ahead of anything. So a lot of the times if someone's experienced hallucinations or delusions and they're getting aggressive, that's when okay, well, maybe something to help them with agitation, we should give them something. But by that point, it's either not effective or it's really challenging to get someone to take medication. So this is where it comes in, where we want to keep a detailed log of what behavior are they experiencing, it were there triggers, what what happened in that entire situation. Because when we're living in it, it's hard to pull ourselves out and see if there's patterns. But when we write it down and we reflect, we can see, oh, okay, yeah, like every day at 10 o'clock, this thing happens, right? So making sure that we're paying attention. If we realize like every day at 2 o'clock, someone becomes really, really upset, well, what are we doing about it at 1 o'clock? And talking to the doctor for alternatives. So there can be exploring medication formats like liquid, or there's patches or dissolvable tablets that might be less intimidating or easier. Talking to your doctor about maybe it's the possibility of crushing the medication instead of giving it in the pill form. And not all medications can be crushed, so it's really important to talk to your doctor about that. And we always want to remember that just because we're crushing medications, it does not mean that we're trying to trick the person and hide medications. Always still announce, this is your medication. Maybe it's mixed in a little bit of ice cream, but the goal is not to trick the person. We're there to help them. We just need, want to help them take their medication. And lastly, document and reflect. And I can't stress this enough. Keep a record of successful strategies to tailor future approaches. This is something that was very common in memory care, is behavior tracking. And what was the behavior? What was the time? What were the triggers? And really taking a look at it, because sometimes a person can be a trigger. They see someone and it reminds them of someone from their past, or maybe they just get upset for no reason. So removing that person. Maybe it's the second they go into their room, they become upset. Maybe it's a smell. Maybe it's the lighting. Maybe there's a pattern that scares them. So really taking that chance to pull back and take a deep dive. And again, as a caregiver, when you're in it, it's very stressful and it becomes very overwhelming. But doing these things to try to problem solve and spending that extra time will be beneficial so that you won't experience this in the future. And overall, some key takeaways from these 3 different scenarios for caregivers to focus on is collaboration and not compliance. So you want to avoid confrontation or being a person of authority, which might escalate the paranoia. So it's important that we're working with them and not trying to get them to do what we want. Focus on gentle persistence. If a refusal persists, wait and try again later in a calmer moment. So again, it's easy to start arguing, right? You want them to do this, they don't want to do it, but it's important that we pull back. And if it's not life or death and safety is not an issue, we'll try it again later at a different moment. And maybe when we're both calm. Always seeking professional support. You want to talk to the doctor about ongoing refusal to adjust the care plan or medications as necessary. So again, leading yourself to be more successful and just adjusting times. And you want to always practice patience and empathy, meeting the person where they are emotionally without arguing or dismissing their experience. Again, it's their reality, they're experiencing it. And we want to be adaptable. We want to tailor strategies to the individual's needs and the environment. Every person is different. How we can reassure them and calm them down is going to be different. And working with professional collaboration, so working with healthcare providers, making sure that you're looking for any other underlying causes, working with association, Alzheimer's OC or different organizations to help with game planning, it's going to be very beneficial. Because you only know what you know, and someone can talk to you and say, oh, have you tried this? And you're like, oh, I haven't. Let me try that. The other form of treatment is medication. And right now, there is no FDA-approved drug for the treatment of Alzheimer's disease psychosis. So doctors often go off-label to prescribe an antipsychotic medication that are not approved for dementia-related psychosis. So common antipsychotic medications include Abilify, Haldol, Zyprexa, Seroquel, Risperidol. And in severe cases, antipsychotic medications can help reduce hallucinations, but they can also have serious side effects. As we see on the right side of the screen is a black box warning, which talks about the dangers of and risk of death with using Zyprexa for dementia-related psychosis. In severe cases, antipsychotic medications can help. Oh, I just said that. Current pharmacotherapies for psychosis and Alzheimer's disease have limited efficacy and high toxicity in this age group. And haloperidol is the most studied of these conventional antipsychotics, and it has mild to moderate efficacy relative to placebos in Alzheimer's disease patients with psychosis or agitated behaviors. However, it causes serious side effects, namely Parkinsonism, akathisia, which is feeling restless and the need to move, or tardive dyskinesia, which is involuntary movement. So more recent studies have examined atypical antipsychotics such as risperidone, olanzapine, and aripiprazole. And these medications have efficacy similar to conventional antipsychotics with lower rates of motor side effects. So between the two, atypical antipsychotics are going to be a better bet. However, as with everything, there has been associated with an increased risk of strokes, aneurysms, and issues with balance and coordination. Overall, both conventional and atypical antipsychotics have increased risk of mortality after short-term treatment. Medications such as Aricept and Exelon, they can help reduce hallucinations and other behavioral problems by slowing the progress of the disease. It can help reduce the hallucinations and behavioral problems. So if your loved one's experiencing hallucinations or delusions and they're not on Aricept or Exelon, that might be the better place for them to start. But everything is a conversation with the doctor. Everything is about risk and benefits, right? So if your loved one's hallucinations are so bad that it's impacting care, it's impacting their safety, and it's putting others at risk, then it might be worth the risk of the medications to outweigh that. So again, it's talking to your doctor, it's figuring out what is going to be best for my loved one and what's going to keep them safe. Oh, all of the medications, again, for antipsychotics, there's Abilify, there is Haldol, there's Zyprexa, Seroquel, Risperidol, and our atypical ones are olanzapine, risperidone, aripiprazole, which again, talking to your doctor, everything has side effects. These are not intended for Alzheimer's disease psychosis. They are intended for those experiencing, they're an antipsychotic. So those with schizophrenia, those with, bipolar disorder, those are what those medications are intended for. Now, for our caregivers, again, it's so challenging. And when we care for someone with Alzheimer's disease psychosis, it can lead to a quicker burnout for caregivers because you're frustrated. There's no quick solution to this problem. You can't just say, oh, nope, everything's okay. And that person will understand and say, oh, yes, everything's okay, right? It takes time, it takes effort. So it's really important that our caregivers take care of themselves. And I know that this is always easier said than done. But you have to put yourself first and you have to prioritize your own health. So tips for self-care and stress management include taking breaks. So asking friends and family to help with chores, childcare, or meal preparation. Using respite care to temporarily step away from caregiving and considering adult day cares or home health care and taking a leave from work if you can. So sometimes when we're a caregiver, we are still everything else, right? We have to make our meals, we have to pick up kids, we have chores that we need to do. Having somebody that can come in and help supplement that and take that off our plate can be very beneficial. Adult day health cares, those are places where your loved one can go Monday through Friday, 9 a.m. to 5 p.m. Transportation's included, meals included, activities are included. So that's a wonderful alternative as well during the week. And, if you're working as well, seeing if you can take a leave from work for yourself. It's important that you continue to eat well. Eating a balanced diet with lots of fruits, veggies, whole grains, fish, and healthy fats, and drinking plenty of water. Again, as a caregiver, you tend to go for convenience, which can be fast food. It's prepackaged, but that's not taking care of your health or your brain. So just making sure that you try to eat a well-balanced diet. Exercise, we all know the benefits of exercise and how it does wonders for our brain, for our mood. So going for a walk, try dancing or gardening or playing with a pet, and trying to find an activity that you enjoy. To reduce stress, practice meditation, yoga, or Tai Chi, listening to relaxing music or guided meditations, and scheduling time to do something that you enjoy, and setting limits on what you can do. So saying no if you're not able to do it. And again, as I go through this, and it's just like, who has time for this, right? You're so busy, but you need to make the time. You need to find that time for yourself. And you want to seek support. You want to join a caregiver support group or talk to a friend or family member. You can, if you're really, burning out, considering counseling from a mental health professional or speaking with your doctor about what you can do for treatment for your loved one. When we joining a caregiver support group, it can be in person, it can be online. There are Facebook pages that you just, you can ask a quick question. Somebody will, answer, and you find support. You find people that are going through similar things that you're going through, so you don't feel alone. Caring for someone with Alzheimer's disease is such a unique caregiving experience, unlike anything else, and it can feel very lonely and isolating. So you find somebody that is you can relate to, and again, they may have solutions. You may say, I did this, and they're like, oh, here's something that worked for me. And it can be something that you would have never thought about, but they had their experience and their solutions as well. And it's important to be kind to yourself, forgive yourself when you don't get the result you want, learn from your emotions, and recognize when you need to make a change. So again, accepting you may become frustrated, you may be overwhelmed, and that's all right. But what can you do to make a change? What can you do to not feel stressed or not feel overwhelmed and not get angry? And there's, additional resources, again, support groups, OC Caregiver Resource Center, California Caregiver Resource Center, my association, Alzheimer's Orange County. We all are here for you to help provide support. So to wrap it up and talk about the 11 things to know about Alzheimer's disease psychosis. So what are the most important things to know? Psychosis is common but varies in severity. Symptoms often appear um, in mid to late stages of Alzheimer's disease, and stress and environment can exacerbate the symptoms. So again, with when we are where you are in the stage of your disease is going to influence what types of delusions you experience, if it's more common to have hallucinations. So just being mindful of where that person is in the progression of the disease. Misinterpretations of reality are very common. The brain is trying to make those connections, but they do not have all of the information. Not all individuals with Alzheimer's disease will experience psychosis. And communication is key in managing the symptoms. Communication between you and the person with dementia, communication between you and the doctor as well. Medical evaluation is essential to rule out other causes. Again, not everybody is going to experience psychosis, so not everybody is going to experience delusions and hallucinations. So if those start occurring, it's important to not just take that and say, oh, this is what happens. Talk to your doctor, labs to rule out any underlying causes, such as, a UTI, dehydration, vitamin deficiencies. All of that can exacerbate the symptoms of dementia, but also lead to hallucinations and delusions. Early intervention is key. Again, it's really important that we don't, the longer hallucinations and delusions experience, the worse it can be for the person. So if you notice it, talking to the doctor right away. And safety concerns should be addressed proactively. So whenever we're worried about safety, that needs to be the first thing on our minds that we take care of. Support groups and resources are vital. You can't do this on your own. You need support, making sure that you reach out and have that in place. And lastly, that medications can help, but aren't always necessary or recommended. So again, if someone's experiencing delusions and hallucinations, but they're happy, they're content, it's not bothering them, there's no need to seek treatment. However, medications can be helpful if the person's safety is at risk or the safety of loved ones. So it's important to talk to the doctor and talk about the risk and benefits because, yes, there are side effects with medications, but those risks the benefits might outweigh the risks. So now I encourage you, if you have any questions, I see one question's already in the chat box, which I'll address. But first, this is our helpline number. So if any information you want to get more information, you have any questions and specific questions regarding a loved one that you want to talk through, please feel free to call our helpline. It's 844-373-4400. We are here for you to help you, and we can help guide you in the right direction. And again, I want to thank Acadia Pharmaceuticals for sponsoring this event. And again, come off mute, type it into the chat box if you have a question. But the question in the chat box is, my father accuses me of stealing his personal items and calls people to tell them. What do I do? Send them this link. It causes doubt with siblings and work associates, and he's also giving away our personal finance to people. It's getting very complicated. Okay, yes. So making sure that the people that he's calling understand what his disease and what those symptoms can be, and that that you're unfortunately going through something right now, and that one of the symptoms is stealing and paranoia. But educating them is going to be very important. And then if there is the opportunity, they have phones that you can limit the calls that go in and out. So looking into that or blocking calls so that way he's not able to reach out to those people. And that prevents him from doing that. There's a little bit more of a control. Sometimes people are hesitant to do that because like, oh, well, they want to talk to them. But if it's causing more problems than it's worth right now, that's worth looking into. And then as for the giving away our personal finances to people, I'm not quite sure to the extent of what that is, if that's in person or over the phone. But making sure if he's by himself, um, limiting with what he has access to. And that includes if that's a checkbook or anything of that nature or a credit card. But does anybody else, if, I open this up, if anybody else has feedback or experience dealing with this?
Well, I can you hear me?
Yes.
Okay, that was my question. So,
Oh,
so
okay.
my dad is absolutely obsessed for the last 2 years with his wallet, his checkbook, and all the things that you say he should not have. But there is this problem where I'm the only one taking the classes, and the people like my mother and my siblings, I try to get them to take the classes, but yeah, all the things he's not supposed to have, he has. And then it's the cycle twice a day. We play find the wallet, find the keys, find the this, find the that. And just yesterday he was just so angry and screaming at me that I stole his Rolex watch. And of course I don't know where it is. He's hiding everything. But, I just sit and clam up and don't talk anymore because 'cause I'm so scared of him.
That's unfortunately so common. So with the wallet, is it a very specific wallet or is it one that you could buy multiples of?
We actually have had to do multiples. He loses it, and then all of a sudden he finds it. We have a tracking device in it now,
Oh,
but
okay,
every
good.
once in a while, he somehow gets the tracking device out and hides that. It's an amazing,
Right.
circle, and experience, and, yeah, and regarding our financials, he'll actually, like, hide stuff, hoard stuff, and then when somebody comes over, he sneaks it to them, and then later after they leave, I found out he's given away all of our personal, financial data.
Okay.
It's mortifying,
Right.
um, and so I keep wondering, is this the time, and I know there's a class in July, is this the time that we put him maybe in a place where it's safer for him? Or, this is th that's th that's my conundrum.
That I want to ask my first question, and I'll get to that question. So with his
Okay.
cards and stuff, does he care about the cards in his wallet or he just was looking for cards in his wallet? Like, does he know what his specific credit card looks like? Or is it just, I
Well,
need
he
a
can't
card?
drive anymore. I think it's just, forever, when he was fine, the wallet just sat somewhere and he was great. And now he just every day he finds a new place to hide it.
Yeah, and that's very common. And then if there's time to get him out, like so like what might be beneficial like to the transitions like adult day healthcare
Okay.
and then transitioning him to that so he's gone and then while he's gone you can um put in, try to find his spots and then get everything and refresh it, and then
Yeah.
keeping multiple wallets on hand, like, oh, I can't find my wallet. And it's like, oh, it's in this drawer, right? You have one readily available to get him. And thank you, Jill.
Okay.
She was going to say what I was thinking too is getting like a MasterCard or a Visa gift card, either that
Okay.
has money on it if he cares about the money or doesn't. It's just a card to go into his wallet so he feels like, oh, I have what I need in my wallet. Because sometimes people care, like, where's my license? Other times people just know they're supposed to have something in their wallet.
I
Sometimes it's
get
like
it.
money. And with in regards to the agitation, because the yelling, it's, again, it's removing yourself as what you're doing is, it doesn't feel great to clam up, but if you can't, like, it's just, okay, here's your wallet. Here it is right now. And also with if it's the mail that he's getting access to, if it's possible to
Yeah.
set up like a PO box. And then
Okay,
that way
so
there's not mail coming to the house or having the address changed to somebody else that you trust.
yeah. Uh-huh.
That way, like you get it, you can manage it, and he doesn't have access to it. But if it's like
Yeah.
regular like bills, and then lastly, explaining to people that are coming over, it's the same consistent people just saying, hey, you know what, like, unfortunately, my dad has Alzheimer's, and this is something that we're going through right now. Because,
Yeah.
with most things, it is temporary. We're just please help us out. If he gives you anything, please don't open it. Just bring it right back to us. And we appreciate your, you being,
Okay.
you being there for us and helping us with this,
So say
because
it up front. Okay.
yeah, because
Yeah.
they don't know what's going on. They're looking at the mail and they're like, "What is this?" And it allows them to have a better relationship with him too, because they might be like, "What's going on?" Like, but they'll come from a place of more understanding, but just letting them know ahead of time, like this is just something that we're going through right now, and if you can help support us, and just if he gives you something saying, "Oh, okay, thank you. I'll look into this. I'll see what's going on," or, "I know your daughter would never do anything to harm you, and we'll talk to your wife," and just making sure. But and unfortunately, with families, it's so hard. I know that we can help with the care consultation if that's something you're interested in bringing your family in for. Um, but they have to be educated on what's going on.
I
But it
know,
takes
and the problem
time.
was, yeah, people in my family, they experienced this maybe 30 years ago, and they said, "Oh, if you put that in a place, they're just gonna drug them up." And I think, like, I said, "No, things have changed in 30 years. We've learned a lot, not everything, but the problem is changing my siblings' minds. My siblings are in their close to 70, and my dad is 90, so it's I'm dealing with a lot of issues. So, but thank you for these classes. I keep taking them, and they're very helpful. I
Oh,
appreciate
good.
you.
Oh, good, good. And a couple other questions. Would vivid dreams or nightmares be considered part of psychosis? Generally, no. Certain types of dementias, like Parkinson's type dementia, how that affects the brain, we would see more vivid dreams or nightmares. So it could be dependent on the type of dementia an individual has. This will be recorded and available on our YouTube page. I will send the link out to everyone after this. Um, Susan said, my husband's has vascular dementia and aphasia. He's been hallucinating for 5 years, which has been scary. He's on Seroquel and risperidone, and has helped immensely. So again, there are medications, and they can be very, very beneficial depending on the severity of the hallucinations and the delusions. And then Ruth Ann mentioned as well, for those that might be um, with someone who is delusional and paranoid, if they have access to financial institutions, making sure that you change the passwords, and then don't give him access. So any information he passes on is wrong. So that's, if we might have somebody who thinks, oh, my wife is stealing from me, can you go check my accounts and give that information to somebody because they trust that person? So changing all the passwords, letting the banks know, I need to put an alert on my account if there's any large purchases or any monies moved, and just having that open conversation with the organization as well. As Susan also said, I also bought a decal for the front door, so it looks like a bookshelf if he wanders. The Alzheimer store has clever ideas as well. So if we have somebody that wanders, the front doors are always the first place you go, right? Because you're like, I'm going to get out of here. I need to get out of here. But having the door covered, it doesn't look like an exit, and the person usually goes up to it and then turns around and goes somewhere else. So those are all excellent suggestions and information. I appreciate everybody sharing. Um, is there any other questions? Okay. If there are, you can email me, or you can call our helpline. It's been a lot of information, so I'm sure questions will come up later on, or you might have a specific instance that you want to talk about, but you didn't feel comfortable sharing it here. Please, I encourage you to call us. I will send the YouTube link where this will be available. It'll be available early next week on our YouTube page. But other than that, if there's no other questions, I hope everybody has an excellent rest of their day, and I'll see you all soon. Thank you.